everybody, guess what? It's Stuart here, and I'm here with Dr. Boster tonight. And, you know, we are doing something different. I'm actually working from my home tonight, and Dr. Boster looks like he's at his as well. And, you know, we're going to be doing something a little bit different. We're doing something for men with MS tonight, right? All right, but for tonight's program, this is an MS Neuro TV program, as you can see. And we have our sponsors for tonight. We have Bristol-Myers Squibb, and we have, I don't know, we have somebody, but okay.
Biogen?
So we got to go to the next screen. Because I can't see that. There we go. We got Bristol-Myers Squibb, and we got Biogen. Thank you. And so my tech guy is a little bit behind me tonight. And for everybody that doesn't know me, my name is Stuart Schlossman. I'm an MS patient first, all right? And I'm starting to put that into my signature all the time. I'm an MS patient first, and I'm also president and founder of MS Views and News. All right, so for tonight's program, though, we wanted to do something different, all right? We wanted to do something because, you know, I'm involved with a lot of different patient advocacy boards, and the problem that most men have with multiple sclerosis is that they just don't understand when they're having all these issues, you know, these sexual issues or these health issues that are coming up. And so I wanted to have Dr. Aaron Boster, who's on here tonight, and Dr. Aaron Boster is going to speak with you all for about 30 or 35 minutes. I know it says a little bit longer, but it's actually 30 or 35 minutes. He's going to speak, and then we're just going to open up to Q&A. And again, this is a men's program tonight, so we're not talking about women's issues with MS. We're talking about men's issues with MS, okay? And Dr. Boster, I'm going to let you have the mic. I'm going to let you take it away, and I'm going to sign out, and I'll come back in 30 minutes, okay?
Fantastic. Let me start by welcoming everyone this evening. Stuart and MS Views and News, thank you so much for this invitation and this opportunity to talk with you guys. If you're unfamiliar with MS Views and News, they are a fantastic organization run by people impacted by MS, really bringing sort of cutting-edge information to the forefront. I've been working with MS Views and News for a few years now, and I absolutely adore the opportunity. So thank you again for this opportunity to talk to you about something which is not spoken about enough. We do not spend enough time talking about issues related to men and multiple sclerosis. Now, the reality is that in the field of multiple sclerosis, this is a disease predominated by women. And in 2021, there is a 3-to-1 ratio of women to men developing MS. And something which is really fascinating, if you go back in time to the 1960s, it was almost 1-to-1. It was like 1.5-to-1 in favor of women. And over the subsequent 20, 30, 40 years, we have seen an uptick of MS internationally only in women. The incidence of multiple sclerosis amongst men has not increased, but it has gone up substantially in women. And that is our first clue that there is some gender dysmorphism. There is something about being a boy as opposed to being a girl, which treats this disease differently. And so my first point that I'd like to make to you is that men are less likely to develop multiple sclerosis as compared to women. Now, the average age of onset for men and women is the same. So the average age of onset, 29 to 30 years of age for the more common form of MS, relapsing MS, and that's true in boys and girls. And in the setting of primary progressive MS, the average age of onset is 40 in both men and women. Now, earlier when I said that the ratio was 3-to-1 women to men, I was talking about relapsing MS. In the setting of primary progressive MS, a less common form of MS, that ratio is actually 1-to-1, men to women. And so right off the bat, there are some differences in the number of the frequency that the various sexes develop the condition. So men are less likely to develop MS. However, if a gentleman has MS, he is more likely to progress at a faster pace than women. So more women get MS, but more men progress faster. So when you're looking at what we call prognosis, our ability to look into a proverbial crystal ball and help comment on what we think is coming down the pike, and we look at the risks of bad outcomes in MS, being a boy is an independent risk factor for more aggressive disease. So gentlemen with MS, before we look at any other risk factors, they're already predisposed to have a more aggressive disease course. Now, having done clinical MS for over a decade and a half, I can share with you that that also mirrors my clinical experience. that women develop MS way more often than men, but when men develop MS, it tends to be a more aggressive and severe course. Now, that's not where the gender differences stop. In fact, it gets even more interesting. So we talked, for example, about the use of disease-modifying therapies. There aren't a lot of studies that split boys and girls when studying disease-modifying therapies, but we do have some data, and most of the time, men and women fare in their response to DMT is about the same. But there's been a couple instances where some really, really interesting data was revealed. And both of the data sets that I'm going to share with you right now come from the primary progressive data set. So looking at men and women in clinical trials with primary progressive MS. The first trial that I want to talk about is an older trial called PROMISE. And PROMISE was one of the very first investigations looking at trying to treat PPMS. Both men and women with primary progressive MS were enrolled, and half the patients were given a dummy shot, so a placebo. Half the patients were taking glatiramer acetate, so Copaxone, with a goal of slowing down PPMS. And the results of the PROMISE trial were it didn't work. There was a zero. It was not successful. And so when you look at the data of both men and women pooled together, we saw that it wasn't helpful in slowing down MS. However, when you do what's called a subgroup analysis, where you separate out subgroups, one of the things they did is they separated boys from girls. And what they found was remarkable. Men with PPMS had slower disease course if they were randomly assigned to take Copaxone compared to men with PPMS that didn't take the Copaxone, the ones that were on placebo. And so that was a very interesting observation because it didn't matter in women. So when you put the boys and girls together, the trial didn't work. But when you separate them, it didn't work in women, but it worked in men. Fascinating. Now, that was inadequate to achieve FDA approval, and so Copaxone was not approved for men with PPMS. Although I will share with you that until the next trial I talk about, until other drugs were developed to treat PPMS, I would routinely place men with PPMS on Copaxone based on that data. Now, Copaxone is an older medicine. It's been around for a long time, and there's some newer medicines that have come out. And there are some newer medicines that have been tested in the setting of primary progressive MS, including one drug which has achieved FDA approval for PPMS, and that's ocrelizumab, codename for Ocrevus. Ocrevus is a monoclonal antibody. It's an IV infused in the vein, taken twice a year. And I am very honored to have participated in the Oratorio trial. So the Oratorio trial was an investigation that we conducted in primary progressive MS, where we enrolled both men and women with PPMS, and we randomly assigned them to either get real Ocrevus 2-to-1, placebo the other group. So 2 people got Ocrevus, 1 person got placebo, but none of them knew it. They all didn't know what they were on. It was blinded. And the overall trial was positive. And so it's the only drug that has been successfully FDA approved to take for PPMS. When you do a subgroup analysis, again, when you look at subgroups within the population and you separate out boys and girls, we saw a really remarkable and somewhat disconcerting breakdown, that it appeared that the driver for success was men. Men with PPMS drove the results of the trial. And when you subgrouped out and looked just at women, it didn't look like it was as statistically significant. Now, does that mean that if you're a woman listening to this talk and you have PPMS on Ocre, you should stop? No, it doesn't mean that at all. I'm simply pointing out that there are several differences about boys and girls in the setting of MS. So far, we've talked about the fact that women are more likely to develop MS. We've talked about the fact that if a gentleman has MS, he has a faster progression of neurological disability. And I've highlighted the fact that at least as it relates to progression to primary progressive MS, there are some sex differences, boy versus girl, which I find very interesting. Now, my next topic really gets into how we manage gentlemen with multiple sclerosis. And I want to talk about secondary sex characteristics, and I want to talk about testosterone. And so when we are born, if we're assigned an XX chromosome, we are biologically a female, and our genitalia and our ovaries produce lots of estrogen. If we have an XY chromosome, then we have a genetic pathway to build a male, and the testes produce testosterone. And so those are sex hormones, testosterone in men, estrogen in women. And it's very interesting that in the setting of multiple sclerosis, if a gentleman has low testosterone, his disease is much worse. Allow me to repeat. Men with MS who have low T, have low testosterone, have a lot of bad things happen. Number one, sexual dysfunction, which we will come back to and spend the majority of the next 15 minutes discussing. Number two, cognitive impairment. Now, before you make some joke about low testosterone making it hard to think, that's actually true. And so when we study men with MS who have low testosterone, we find that they have an increased risk of cognitive impairment with difficulties in thinking and memory. And when you supplement their testosterone, not only do they have improved libido and an improved erectile function, but they also think more clearly. Now, the next comment is arguably the most important. Men with MS who have a low testosterone progress in their neurological disability faster. So if you have two guys with MS, any kind of MS, relapsing MS or PPMS, and one guy has a normal testosterone level and the other guy has a low testosterone level, the second guy is going to get worse much, much faster than the first guy. Now, this is a major concern because all too often I feel like MS neurologists don't remember that or don't think about that, and they're not checking testosterone levels in patients. I, by protocol, check testosterone in all of my MS patients when they come to clinic once a year. And if their testosterone level is below 300, or even sometimes below 200 or 350, I am concerned about low T. And so I want to spend just a few minutes talking about how we work up low testosterone and kind of the ways in which we can supplement it. So the first thing is men have the highest testosterone first thing in the morning. And so if you're checking for low testosterone, you want to check it first thing in the morning because you want it to be at its peak in your body, because maybe you have a low T in the evening, but it's normal during the day, and that doesn't count. And so we want to make sure that we're drawing a total testosterone level in the morning time. And if you have one low number, I don't want to accept that as gospel. I want to repeat it. So a week or two later, I'll ask you to repeat it. And if you have two low testosterone levels, then I am concerned that we need to start supplementation. Now, you don't just run into taking anabolic steroids. We have to check a couple things because it can accelerate prostatic hypertrophy and increase risks with prostate. And so we need to check a PSA and to make sure that the PSA is not elevated. We need to make sure that we don't have issues with high blood pressure and other cardiovascular risk factors. Now, at the Boster Center for MS, where I practice MS neurology, I do that testing myself, although it's not uncommon that we would send a gentleman to a urologist or an endocrinologist, and they do this kind of testing routinely. If we identify a guy with MS who has low testosterone on 2 occasions, and there are no contraindications to treating him, I start him on testosterone supplementation. Now, there's lots of different ways to take testosterone. The way that I've been using during the global viral pandemic this past year is a version of testosterone which is injected in the muscle, so subcutaneously. It's a prefilled syringe that you take once or twice a month, whack, and you give yourself an injection. There are many other ways of taking testosterone. Another very common way is a gel that you rub on your skin. You have to make sure that you let it dry. You have to make sure you get it off your hands and that you're not touching your wife's face because you don't want her to grow hair. And then what we can do is we can follow the testosterone level. And so when I follow up with my patients, my male patients with MS with low T, and I'm giving them a monthly or a twice monthly shot of testosterone, I want to see that level climb above 400. And in addition to that, it's my expectation that they're going to have more energy, that they're going to think more clearly, that the bedroom is going to become a lot more fun, and we're going to slow their neurological disability. So If you are a gentleman with MS listening to me talk right now, I ask you the following question. When is the last time you had your testosterone checked? Are you having any difficulties in the bedroom with the down theres? Are you having any cog fog? And are you concerned about rates of progression? So if you said yes to any of those comments, then I want you to ask your MS neurologist to please check your testosterone level. And it should be in the morning. I recommend a total testosterone. And if your MS neurologist says, well, I don't do that, say, fine, send me to a urologist and I'll ask the urologist to do it. Because treating men's testosterone is an awesome way of improving multiple things that we care a lot about in the setting of multiple sclerosis. Now, if you remember when I was talking about men with low T, I commented that one of the things we can see is sexual dysfunction. And I want to spend the next 10 minutes or so discussing sexual dysfunction with you. So if you're uncomfortable with terms like penis or vagina or orgasm, then you might want to watch a different live stream. But if you're a guy or a gal who enjoys quality of life, you like eating good foods and drinking good beverages and enjoying sex when you're allowed, this is something you want to stay and listen to. So it's very common in MS that we can have spinal cord damage. That's very common in MS. And it's very common in MS we can have brain damage. And the sexual organ of the body is really the brain and spinal cord. That's the circuitry that runs the down theres. And all too often in the setting of multiple sclerosis, men can develop difficulties with sex. So there's very few things in life which ruin your quality of life than to mess up the bedroom. If you have difficulty obtaining an erection, maintaining an erection, or ejaculating, or if you have difficulty on the down theres, either because you can't feel them or because they hurt, or if you have an extensor spasm and your leg gets thrown out and it hurts like the dickens, it makes Friday night kind of suck. And so I want to talk a little bit about sexual dysfunction in men with MS, and then I want to talk about what we can do to make it better. So when I think about sex, I like to divide sexual dysfunction into three categories: primary sexual dysfunction, secondary sexual dysfunction, and tertiary sexual dysfunction. So let's talk about all three. Primary sexual dysfunction is when the circuitry of sex, so the brain wiring to the spinal cord, wiring to the down theres, that circuitry has been damaged by MS. And this is unfortunately very common. So when the down theres are fortunate enough to be stimulated, it needs to send a message all the way up the spinal cord to your brain to tell your brain, hey, guess what? And then your brain says, okay. And it sends a message back down the spinal cord so that you can have an adequate erection for vaginal penetration and orgasm, or however else you enjoy having sex. Now, that can become a problem when you have spinal cord lesions from MS. So, for example, as I speak to you right now, I'm using my indoor voice. I'm not screaming, I'm not yelling, I'm just talking casually. Why? Because there's no interference between my mouth and my microphone, and there's no interference between your speaker and your ear. So there's no cause for me talking loudly. Let's pretend that I brought my clinic staff in the room. Now, I'm in my office, it's after hours, there's no clinic staff here, but if they were, and I brought them all in the office, and we had a bunch of people here from the Boster Center, and they're all chatting and talking and moving about, it would be really hard for you to hear me because there would be so much interference between my mouth and my microphone that you would have trouble hearing. And so what I would have to do is I would have to provide overdrive stimulation. I would have to yell at the top of my lungs to overcome the interference from the ambient noise in the room. The same thing can happen with primary sexual dysfunction. So when you have the down there stimulated, the message dies along the way and it never gets to your brain. The first tool that I want to teach you when addressing primary sexual dysfunction is the vibrator trick. And so this is not something I learned in med school. On the contrary, after the third guy said, hey, guess what? I stole my wife's vibrator and I orgasmed, I started to realize that they were onto something. So here's what I've settled on. If you have primary sexual dysfunction, if it's difficult for your brain to inform your down theres that it's time to do fun things in the bedroom, then you can use a plug-in-the-wall vibrator and a water-based lubricant as follows. Number one, apply water-based lubricant to your junk. Why? It increases skin sensitivity. So you have an increased sensitivity of your skin, and that will help increase the sensation so your brain's more likely to know what's going on. Number two, I want you to use a Hitachi magic wand. Now, I don't own stock in Hitachi magic wand. I probably should. I don't get a kickback from Hitachi magic wand. They don't know I exist. But the Hitachi magic wand is magic, like literally. It's sold as a back massager for like $50, and it is a plug-in-the-wall vibrator. It's like super hardcore powerful. And it is an opportunity for you to apply overdrive stimulation. So you can place the head of that plug-in-the-wall vibrator on the glans penis, on the shaft of the penis, under the testicles. You can put it wherever it feels good. And what will happen is it's so powerful that it's providing overdrive stimulation. It's the equivalent of me yelling so that you can hear me. And you can apply that during intercourse. You can apply that on your own. You can apply that literally during foreplay. Now, this is really funny. I'm in my office at night, and I just had two wonderful team members who come in to clean the office. And I'm sitting here screaming about penises and vibrators. And so they're kind of looking at me funny. But maybe they'll learn some stuff. Maybe they'll buy a Hitachi magic wand. And you literally can use the Hitachi magic wand during intercourse. You can literally hold it between you and your partner. I'll share with you that over the years in recommending this tool, the vibrator trick, many, many men have come back to me with a thumbs up and said, hey, that was awesome. It was adequate for vaginal penetration. It was adequate for orgasm. It really, really improved Friday night. And so that's one tool that we can use to assist with primary sexual dysfunction. There's another one, a little blue after dinner mint called Viagra, or its cousin Cialis, or one of the generic knockoff brands. Now, what these medicines do is they interfere with the way that blood flows. So the way that the down there's work anatomically is when you're aroused, blood flows into the glans penis, and there are valves that snap shut. So it fills with blood, and you have what's called a hydrostatic skeletal buildup, which you are familiar with as an erection or a boner, and that allows an adequate for penetration. And so sometimes, because of primary sexual dysfunction from MS, it's hard to do that. And you don't have adequate erection for vaginal penetration or for orgasm. So if you take a little blue after dinner mint, it can change everything. Now, if a gentleman with MS has erectile dysfunction and doesn't care, then I don't care. But if a gentleman with MS has erectile dysfunction and he doesn't like it, I'm going to send him a script for Viagra or for Cialis. And I want to teach all of you a secret trick. So come here, I want to tell you something, but don't tell anyone else, okay? Viagra is really expensive. And sometimes through insurance, they'll only give you a couple pills and they'll charge you out the nose for it. And I've actually had guys say, I can't afford that. I guess I'm going to have to forego intercourse. Not true. There is a program, it's an app, which you can download for free on your phone, and it's called GoodRx. I don't know if that's showing up for you. Again, I don't have a relationship with them. I don't get a financial kickback. I just think it's a really cool program. And this is a living, I would say it's a coupon. All right, so it's kind of more than a coupon, but let's call it a coupon. And you can type in Viagra, and you can type in your zip code. And here I typed in 30 pills of 100 milligrams each, enter. And I can use this GoodRx coupon. I can go to my Kroger's, which is 1.2 miles from here, and I can purchase 30 100 milligram Viagras for $15.44. Or I can go to Giant Eagle, which is 3 miles from my office, for $18.53. My point here is sometimes these medicines can become cost prohibitive through insurance. And if you can use a tool like GoodRx, you might be able to score 30 pills of Viagra for a price that you can afford. Now, how do you make that work? You talk to your MS neurologist or your neurologist and say, hey, I'm having some trouble. I would like to try out some Viagra. Give me a script, a wet script. So like have them like give you, like from a script pad. And you can take that with the GoodRx coupon that you downloaded on the app. And you can take that to your friendly neighborhood Kroger's or Piggly Wiggly or wherever and get it at a discount. And so I think that's a super, super important tool. Now, you remember I told you there are three kinds of sexual dysfunction, and the first one is primary sexual dysfunction, and we're going to combat that with a little Viagra and with a plug-in-the-wall vibrator and a water-based lubricant. What's secondary sexual dysfunction? Secondary sexual dysfunction is not a problem with the circuitry of sex. It's a problem with symptoms of MS that can impair the bedroom. So, for example, if you're having intercourse and you lose control of your bladder or your bowels, you're probably done having intercourse, right? That's not very sexy. And even if you have an urge to urinate, that can ruin sex. And so bladder and bowel dysfunction, which very frequently accompanies sexual dysfunction, can really interfere with feeling sexy and awesome. What's another example? Another example is neuropathic pain. Some men may develop a painful sensation in the down theirs. So when they're touched, it doesn't feel nice, it hurts. And there's actually a fancy doctor term for that called dyspareunia. You could have burning of your leg, and when your partner's touching your leg during intercourse, it hurts and it kind of ruins the mood. One of the most common culprits in destroying a happy Friday evening is spasms, spasticity, cramps, Charlie horses. You're having sex and loving life, and then your leg goes into a massive spasm and cramps up, and you're sitting there screaming, trying to rock, while your partner says, honey, are you okay? And secondary sexual dysfunction is a real monster. Now, how do you combat secondary sexual dysfunction? You have to identify which symptoms are bothering you, and you have to treat it. For example, let's use spasticity. I have a patient who is a fantastic gentleman. He has not very fantastic PPMS. It's a pretty bad disease. He has really, really bad spasticity. His spasticity is so bad that he has a pump in his body, a baclofen pump, to deliver baclofen because he needs that high of a dose. Because if he were to take oral baclofen pills, he would have to take so much that he was in a coma to control his spasticity. And I've been taking care of him, and I know his family very well for many, many years. And he and his wife are very open with me about difficulties in the bedroom. And the biggest difficulty is that his leg goes into spasm during intercourse. So they're trying to have sex, and partway through, his leg curls up and hurts, and it ruins the mood. And so they tried with a different doctor, Valium, because Valium can help spasms. And when he took Valium, he didn't have any spasms, and he literally fell asleep during sex, which his wife did not appreciate. And so that wasn't going to be successful. Now, I'm talking to him once, and it dawned on me that he has spasms in the MRI machine. And so we came up with a technique where before he has an MRI, he stops by my office, and I program his baclofen pump to give him a bolus of baclofen, and that helps his legs relax, and that helps him not spasm, and then he has an MRI. Ha-ha! So we came up with a tool. We gave him a special device. It's called a PTM. It's like a pager, and it's hooked to his pump through the interwebs or through Bluetooth. And he can trigger a bolus. So he can make his pump give him a bolus. And I gave it to him to take home. So now when he and his wife want to have intercourse, 15, 20 minutes beforehand, he hits the button. It boluses the intrathecal baclofen. He doesn't get sleepy or groggy, and he doesn't have spasms. And so I'm very proud of that because I think that's an awesome way of overcoming secondary sexual dysfunction. Now, the third category of dysfunction in sex is tertiary sexual dysfunction. So primary sexual dysfunction is where the circuitry of sex is messed up, and we can combat that with Viagra or Cialis or what have you, and we can combat that with the vibrator trick. Secondary sexual dysfunction is when symptoms interfere with sex, like spasms or bladder, the way I just described. Tertiary sexual dysfunction is different. It's when you don't feel like a sexual being. You feel ill. You feel like an invalid. You don't feel sexy. And that is something which is overcomable by talk therapy, by discussing that, and by open communications with your significant other, with your sexual partner. And that's something that we can talk through even in clinic. My name's Aaron Boster, and as always, thank you for learning about MS with me, and in particular tonight, thank you so much for letting me talk about one of my absolutely favorite topics, men's issues in MS, with a focus on sex and making the bedroom better. And with that, I would like to invite our friends from MS Views and News, specifically Stuart, to come back online so that we can field your questions.
I have lots of questions that have come in, and first off, I want to thank you again for this awesome topic. So many people need to hear these hear what's going on with this. I see online we do have over 50 people online. I am going to say that for a change, we have a lot more men on this call than we have women on the call, and that's a great thing because it's usually the other way around. All right, so we're getting questions though from men. We're getting questions from women. I'm sure the women, who knows, they could be care partners of the men. I really don't know. I really don't care, but the questions are great, so I'm going to start up, all right? All right, so the first one is a person wants to know if they could use Cialis or Viagra while having heart issues and that they're on beta blockers. What's the answer to that?
So the answer to that is I can't give that individual human whose name I don't know and whose medical condition I don't know specific advice for them. They bring up a really important point that all medicines have side effects. And if you have cardiovascular issues, you don't want to just score some Viagra and take it because there could be some heart-related problems or hypertension or what have you. So the thing to do is to talk to your primary care doctor or your cardiologist and say, hey, is it okay if I take Viagra or Cialis? They may actually want to do a cardiac workup to make sure that you're not going to put yourself at risk. It's a really good point that you bring up. I want you to bring that to your neurologist or to your primary care doctor so they can clear you for awesome intercourse with an assistance device such as Viagra.
Great, thank you for that. So most of the time when we do these events, I name the people that are asking questions. I'm not doing that tonight, everybody, okay? I'm not going to say your name. If I do, I'm not going to call you by your real name, all right? So don't worry about it. If you want to ask a question, come on here and ask a question. Please, everybody, remember that we are only taking questions that are relative or relevant to the topics that were just discussed, all right? So if you want to ask about something to do with COVID, that's not tonight's program, okay? All right. All right, next. All right, so we have a person now in continuation of the Viagra Cialis. Can we become immune to or used to either of those medications?
In my experience, sometimes they can stop working or we need different doses. Let's talk for a little bit about other medical things we can do to help men's erections, because there's actually several things we can do. So there's Viagra at different doses. Oftentimes we start off at 50 milligrams. Some gentlemen need 100 milligrams. Cialis comes in several different dosing regimens as well. If those pills don't work, there are still many other options. Now, in the era pre-Viagra and those pills, there was an option of injecting the side of your penis. Now, the first thing most guys say is, no, thank you, but it's an extremely effective way. An intercavernous injection in the side of the shaft of the penis can result in a fantastic erection to allow intercourse. And if a gentleman is having erectile dysfunction and Viagra or Cialis aren't working, if he cares enough about it, he can try this route. And that's typically very, very successful. There's even steps beyond that. I have some patients that have profound sexual dysfunction. They're unable to obtain an erection, not at all. And they've tried Cialis, they've tried Viagra, they've tried these interbubble cavernosus injections, nothing works. And so they have a very simple surgery where they have a penile implant inside the shaft of the penis, and then they have an erection all the time. There's actually different kinds. You can have some that deflate and blow back up. You can have some that are erect all the time. And I can tell you from several anecdotal experiences with my patients, they love it. They think it's fantastic. And so really what it boils down to is how much do you care? And if the Viagra and the Cialis aren't working, the first thing we want to do is talk to your doctor, see if maybe we need to change brands or doses. But even if that doesn't work, we're not done yet. We can keep on keeping on until you quit or until things are fantastic.
Okay, thank you. All right, going now to the supplements for like androgel, all right, or like you spoke about the testosterone injections. Can you please tell people the difference in being level on like maybe the gel as opposed to the intramuscular injections that are given for testosterone therapy?
So very excellent point Stuart brings up that it's not just about which way do you want to take your testosterone, but the goal is to create a blood level. And so if you give yourself an injection, sometimes you can see a peak and then a trough. Sometimes we use a lower dose of testosterone and we give injections every other week so that we can kind of maintain a more steady blood level. A different way of accomplishing a steady blood level is to use like an androgen gel, like Stuart mentioned, which you could do daily. And so by doing a daily gel or an every other day gel or what have you, you can maintain a better blood level dose. And so the whole point here is that we want to create a higher level, we want to keep it stable, and we want to follow that with labs. And so for some gentlemen, the androgen gel is the answer, and that works much better for them. If you have questions about this, or if your MS neurologist is maybe not comfortable, because a lot of neurologists are not trained in this area. I was not trained in this area. This is something that I taught myself by reading a bunch of books and talking to urologists and patients. Then I want to remind you that the friendly neighborhood urologist is a rock star at this stuff. This is like part and parcel to what he or she does all day or a day. And so you can always go and talk to them and they'll help you. Same thing with an endocrinologist.
Okay, thank you. All right, so a person now asks, I'm so not used to saying names that I have to say a person, all right? Is there a spray a man can use instead of using the gel or the injection?
So I have to be honest with you and say I don't know. There may be a spray, but I'm not aware of it. And so I don't know if somebody on the line is aware, but it's not something that I'm familiar with. I know that there are different ways of taking testosterone, but that's not one that I'm familiar with.
So I'm going to tell you that there is no spray because I'm familiar with this subject. All right? Okay. Yep. All right. So next, a person is asking, why does testosterone decline and what's up with that?
So I think there's a lot of things. I think that as we age, our testosterone levels decline. I think some men can have low testosterone because of other medical conditions. But I think the point here is we first have to be sensitized that testosterone is important. Second of all, we have to be sensitized that it can be low. And then we have to know to check for it. And I think if you keep in mind those steps, your doctor receiving you can help you figure out by other lab tests and by other investigations, maybe what's causing it and what we can do to treat it. And I just want to point out an example of a young man that I take care of. He's 28 years old. He has 2 young children. He works full time. He's a strapping young man. He's not having any physical disability and he's not having an erectile dysfunction, but he's cognitively impaired and he's exhausted. And we've given him stimulants and it didn't really work. And he's really, really miserable and very depressed. And so we've got him on some antidepressants and we're trying to use stimulants and we're failing. And I checked his testosterone. Now, a normal testosterone level should be above 300, probably above 400. His was 22. Now, the guy's only 28 years old. And I don't know why his testosterone is low. And so right now, he and I are doing an investigation. We're drawing a bunch of blood work. We're really digging into it to see if we can figure it out. And I'm very eager to figure it out because I want to get past that so that I can treat him. Because I suspect that when I start him on testosterone supplementation, the mood's going to get better and he may not need his antidepressant. He might. His energy and his thinking and memory will improve. And most importantly, it's going to slow his disease down so that he can be the best dad and the best husband possible to take care of his family despite having MS.
How was he able to have children with such low T?
I don't know. It's the only time, Stuart, that I've checked his levels. And so I didn't know him before he had children. And so presumably something's happened, but you're absolutely right. I mean, that is a rock bottom low number and it shocked us. This is a young strapping man we would have never suspected. And so I'm really glad that we found that lab so that we can figure it out.
Okay. All right. I'm going to read a question to you. I'm not really getting it, but I'll read it to you and maybe you can get it. All right. If sex isn't all that important for lots of other reasons, but testosterone is low, will T supplementation turn us into Randy Old Goats? I would like to avoid cognitive impairment, obviously.
So that's a good question. The guy's saying, look, it's not like I'm trying to improve the bedroom, but I do care about my health and I care about my thinking and memory and I care about my progression of disability. So maybe I should have my testosterone checked and supplemented, but I'm not looking to become a horny old goat. So it is my experience that when you're supplementing testosterone into normal levels, that doesn't happen. I don't think men become savages, ripping our clothes off and beating our chests and running through the bedroom. But I do think that it can improve the ability to the logistics of sex, erectile function. It has not been my anecdotal experience in talking to men in whom we've supplemented the testosterone that they're unsatiable and that their wives hate me. Not at all. I think it probably helps them move them into a more normal range. I've never had a gentleman tell me that it was a problem and that he really ran into trouble because he couldn't get sex off the brain. I've not heard that.
Okay, thank you. All right, I'm going to continue with the online questions. Then I got all these technical ones in front of me as well. All right, and then we're going to get into some things that what makes a man feel good, and what products can be used. All right, and we'll slow it around like that. Hey, by the way, everybody, I'm not wearing a tie tonight. Isn't that amazing? I just saw, though, that I have this kink in my neck and I got all these wrinkles here. That's not a good thing. I got to go back to wearing a tie again. All right. A person is asking, how accurate is the 30 minutes prior to sex timeline? I'm trying to time it all out right.
I assume they're talking about taking Viagra or taking Cialis. I'm going to assume that they're trying to time taking the medicine so that they're able to have an erection adequately. So the first thing I'll say is a lot of times I want you to consider this as an after dinner mint. So I think that you handle it better when you have some food on your stomach. And you're typically, the package insert's going to tell you that it will improve erectile function for several hours to come. Gentlemen have told me that it improves the quality of their erections. So it's not that they don't get erect, it's that they have a more significant erection. Some men have divulged that if they're lucky enough to have several opportunities to have sex in one evening, that when they go the second or third time, that it makes it more meaningful and they're able to play ball. And so I think all of those things are important. The reality is you're going to figure out for you what works best. What would I consider doing? I would try to have the pill in my pocket. And when we're about an hour before intercourse or half an hour before intercourse, and we think we might have intercourse, I would try taking it. And then you just have to pay attention to the timing. Some men tell me that if they take Viagra, that even up for 12 hours later, if they have stimulation, they have a very significant erection. And everybody's a little different. And so it does take a little bit of trial and error. I would consider that a pretty fun homework assignment, trying to dial it in. I also want to share with you that there is a product called Daily Cialis. It's a lower dose of Cialis, which is taken every day, independent of if you get lucky or not. And the goal there is when you happen to have a chance to have intercourse, your body's ready. And so that's another way of addressing this concern if timing it is challenging.
Okay, thank you. All right, now let's talk about something a little bit different. So there are guys, there's a few of them that have actually written in. Tell us about the ups and the downs. So they're very erect. They are very, very interested in what they're doing. They're very, very delighted with who they're with, and they're having a great time. And then all of a sudden,
yep.
during intercourse, all right? And then that comes back out, all right? And maybe they do something a little bit manually, okay, he or she, and it goes back up again. And they go to get back inside again and back down again. So is that literally a more friction problem than other?
There's a lot of things that go into that. The very most important thing is to have a sexual partner that you can communicate with. And I can't stress this enough. I need you to be able to talk openly about that with your sex partner. And if you're not able to have a conversation with your sex partner, then I'm wondering about that relationship, if I'm honest with you. Right? Because the most important thing is for the two of you to be talking, right? There's no shame in that game. I don't have MS. I'm in my 40s and that's happened to me, right? There's no shame in that game. And what's important is to be able to say, gosh darn it, that's frustrating. Let's take pause. Let's do some other things. Let's revisit. Let's try a different position. Let's try a different activity. And so if you can simply talk to your partner, what that's going to do is it's going to alleviate the anxiety and stress, guilt, concern, fear that you have, and it's going to help your sex partner also not feel awkward or uncomfortable. And it allows you guys to say, hey, the current activity is not working. Let's switch it up, All right. So that's the first thing, is I think it's really, really important to have that conversation. Now, if we think about that, we've been discussing Viagra and Cialis, those can help very much with that exact problem, because it's not just about obtaining an erection, it's about maintaining the erection. And so many gentlemen will find that if they take a pill like we've been discussing, it doesn't just help with obtaining, but then they can maintain the erection. There are other things that we can do. So you can use a vacuum pump. So if you've ever seen, what's that funny movie with, my story is stupid because I can't think of it, but there was a comedian that had a very funny movie where one of the characters had a vacuum pump and they found it and they teased him about it. But oftentimes what you're doing with a vacuum pump is you place this over the penis and you suck the air out, and it forces the penis to engorge with blood. And then you roll down the shaft of this tube onto the base of the penis, a rubber band, like a special rubber band, so it doesn't hurt. And what it does is it holds the blood in the shaft of the penis so that you can maintain a massive erection so that you don't lose the erection during sex. Austin Powers, that was it. So in one of the Austin Powers movie, he uses that and he says, "It's not my bag, baby," but it is. And again, that's a most excellent way that you can maintain an erection by doing that. There are other things you can do. It might be inadequate from a stimulation standpoint to have just vaginal intercourse or anal intercourse or what have you. And so you can use other tools. Remember that plug-in-the-wall vibrator? Take that plug-in-the-wall vibrator and hold it at the base of your penis while you're having intercourse. And so it's constantly vibrating and stimulating the shaft of the penis. And very often that will assist in erectile function. So I think that we need to have open communication. We need to be comfortable talking about this. And I want you to keep in mind that there are many maneuvers, whether that be a vacuum pump, whether that be a Cialis or a Viagra, whether that be a plug-in-the-wall vibrator, to help maintain erection.
What about for those, though, that have complete lack of feeling in the down under? So where there's not enough sensation, how to get around that? Because I'm reading a question also.
So that can be challenging, no question about it. And again, we want to make sure that we're removing any barriers that are there. We want to make sure that we don't have a full bladder, full bowel. We want to make sure that we're dealing with spasms. We want to make sure that we're not on medicines that can dampen sensation or interfere with sexual function. I hate to tell you this, but SSRI antidepressants like Prozac, Paxil, Zoloft can interfere with sexual function. And so your doctor with very good intentions may place you on that, and you may find that you don't have as good a sensation or erectile function. Something to keep in mind. That's why I love using Wellbutrin in my patients, because that's an antidepressant that doesn't really impact sexual function. Again, I think it's very, very important to talk to your partner, because if you have MS and it's made it so that your sensations decreased, you may find another location that is intact. And so it might not be the head of the penis. It may be the testicles. It may be your inner leg. It may be some other area. And if you can figure out where that area is and you can coach your partner to help you stimulate that area, you still might have a degree of success. The take home here, Stuart, communication. That's so important.
Right. So going forward with the communication. So there are those guys, though, that now they know that they have all these issues going on, all right? And they're going in there now with like this negativity in their mind. This is not going to work, try everything you want, but I doubt it's going to work, So how do they get past the emotional draw of it, the letdown, where, they're feeling bad to begin with before they even get comfortable to feel happy?
Yeah, and so that really gets into the psychology of the human being. It's such an important topic, and it happens very, very often. So let me tell you a story about a young man that I know who has MS, and he had a pretty bad spinal cord attack. So he has significant difficulty with walking. He can walk, but he has significant difficulty walking, and he has complete and utter erectile dysfunction. And he has tried everything up to a penile implant, but he doesn't want to do that, and he's not able to have intercourse. And so he has a significant other who's his fiance, and he said, "I'm really concerned." And she looked him in the eyes and said, "Does your mouth still work?" Now, the reason I brought that up was she said something beautiful. She said, fine, so you and I are not going to have vaginal penetration with your penis, but maybe there's another way that you can pleasure me. And he has had a meaningful sexual relationship with her for years since then. They have a tremendous amount of oral sex. Apparently, he's very good at it. God bless. And my point here is there's many different ways of achieving a fantastic evening. And if you can simply talk to your partner about it, you can come up with a different game plan. Sex doesn't have to be what the missionary position where the penis goes in the vagina and that's it. Sex can be multiple different exciting and fantastic things defined by you and your partner or you and your 10 partners, however it is that you're choosing to do it. And so it doesn't have to be the traditional thing that you learned about in Sunday school. No, it can be extremely varied. And so again, I go back to communication. So important, in expectations. And I want you to feel comfortable saying, hey, this is hard for me and it's really stressing me out. Can we talk about it? And if your partner says no, I question the validity of your partner.
So a guy just wrote, sometimes I'm scared to start because I don't want to fail. I've been happily married for over 40 years. All right. So that's like right in line with what I asked you. Also, another person going back to the sensation, he writes that Dr. Shapiro recommends a bag of frozen peas to create sensation. And then he writes, oops, maybe that's really more for women. so it can be used on both sides, it's obviously.
So, this guy shares that he's been happily married for 40 years. So I'm making assumptions that he's had a monogamous, wonderful relationship with his spouse, and he doesn't want to fail. And I really want to unpack what he said, because we have to define fail. If success is only defined by an 18-year-old's erection and a massive orgasm after some pumping, maybe he's going to fail. But I would rather redefine the goals of the game. So if the goals of the game is intimacy, it's a physical expression of love. If the goals of the game is pleasuring his partner and having an opportunity to be intimate in a way that you can't otherwise, he might have a raging success in the absence of a traditional successful, sexual encounter. And so it goes back to redefining what's important and redefining the goals and talking to your partner. And so I just can't stress that enough. Hopefully, the gentleman who has a happy 40 years of marriage is able to talk to his spouse about that concern. Say, I'm worried about failure. I'm bringing this in the bedroom. Can you help me? I think that's super important.
Great. Thank you. All right. So a guy just writes, sometimes a cool shower, not cold, helps getting erection, but trying to keep it longer.
Let's talk about that. I guess one of the things that we do with an MS is heat sensitivity. And so many people are familiar that someone will have what's called motor fatigue or heat sensitivity. So I'll use an example of walking. And so someone's walking and they're not weak and they're doing great and it's hot outside. And as they keep exerting themselves, their left leg starts to get weaker and weaker and they're dragging their left leg. And pretty soon they have to sit down and rest until their body cools down. And then their leg starts to work again. And it's not just your leg. It can be anything. So there's many things that are heat sensitive. Now, let me share with you a medicine called 4-aminopyridine or delfampridine. The trade name in the United States is Ampera. I don't have a financial backing of Ampera, but I'm a MS neurologist that prescribes it a lot. And Ampera is a medicine that only works in about a third to half of people with MS. And we're not smart enough to know who responds and who doesn't. And so we give it to you for a month. And at the end of the month, then you tell us if it's working. And we tested Ampera in walking speed. Why? It's easy to test walking speed. If you're ambulatory, it takes a couple seconds to measure how fast people walk. But the reality is that 4-aminopyridine, Ampera, works in anything that's heat sensitive. And I want to tell you a very brief story about a family that's very near and dear to my heart. The husband has MS. He's my age. He lived in a town one over from me, and his son and my son are friends. And I've been a guest in their home many, many times. A wonderful guy. And one day he and his wife were in clinic with me and we had a wonderful discussion. We were talking about lots of things. And I got up and I said, I'll see you guys later. And I grabbed the door and his wife said, oh, I forgot to tell you, we tried the Impera. I said, oh, I let go of the door. I said, how'd it go? And she said, well, I will never let you take him off Impera. I said, well, that's nice. And she said, I don't think you understand. I will never let you take him off Impera. And he's got a grin like from ear to ear. And so I sat back down. I said, okay, tell me the story. And she said, well, when my husband developed MS at age 18, he lost erectile function. Now, they had been high school sweethearts. They had been dating this whole time. And in order to have their child, it took extravagant means to obtain sperm so that they could have a child together. And it's been a major issue their whole adult life, which they never mentioned to me until Impera. Now, Impera works to treat heat-sensitive issues. And it turns out that this guy's issue was when he got overheated, the willy went down. And so when he took Impera, he no longer had that trouble. And so he has heat-induced erectile dysfunction. And he's been on Impera for probably the last 10 years, loving life and doing great. And I think that's really cool.
See, it helped him walk better.
That's right. All three legs.
Right. That's right. That's right. All right. So next, what do we have? All right. So going back to now liquids or oils or gels or whatever that can help somebody out, do you recommend a water-based solution or what?
So if we're talking about increasing skin sensitivity, I'm talking about a lubricant. I tend to prefer water-based lubricants because they're easier to clean up and they're not going to stain your sheets or somebody else's sheets. Now, from a medical standpoint, I don't think a water-based lubricant is magic and an oil-based lubricant or some other like synthetic silicone-based lubricant is bad. But I think that you avoid a lot of issues by using a water-based lubricant. So that's what we have at my house, and that's what I recommend to patients.
Okay, thank you. All right, going back to, you're talking about low T. They want to know if using the supplement, whether it be androgel or getting the injection, will make their MS worse.
I'm not aware of any data that a man supplementing his testosterone into normal levels should worsen his disease. The data that I'm familiar with is the opposite, that low levels of testosterone correlate with bad outcomes, with worsening cognitive impairment, with worsening erectile dysfunction, with worsening fatigue, and most importantly, with worsening progression of disability. So in my line of thinking, the way that I review the data, I think that low T increases risk of progression, and supplementing testosterone into a normal level is the thing to do.
Okay, thank you. All right, going now back to your tertiary. All
Third.
right, hard word for me to say. All right, so if that makes a person feel ill, was that when you were recommending the use of antidepressants?
So I think we have to get to the bottom of what we can do to help them feel sexy, right? And so sometimes people suffer from depression and that can bleed into the bedroom. In fact, oftentimes depression bleeds into the bedroom. And so it's not a bad idea to consider an antidepressant, but really we have to get to the crux of what is the issue. All right, and this may involve a psychotherapist, this may involve a couples counselor, this may involve having a very honest, open conversation with Aaron. For example, the gentleman that spoke to us earlier that said he's been happily married for 40 years and he's worried of failure. I wonder, has he told his spouse that? Is that a conversation that he's had? Does the spouse even know that's a fear of his? Maybe the spouse is entering in the bedroom with no knowledge of that. And so I don't want to suggest that if you don't feel sexy, simply take a medicine and that'll fix it. That's not what I'm telling you. What I'm telling you is that sex is a very, very important quality of life measure. I mean, sex and eating good food are ranked way high up there with quality of life for adults. And if you're having difficulty with intercourse, it's worth digging in. And if you just don't feel like a sexy creature, it's worth discussing that. And yes, sometimes treating depression takes care of the problem, but I wouldn't say that's the answer. I think that's one tool of many.
Okay, thank you. All right, going back to the secondary sexual dysfunction that you were talking about when you're talking about spasms. So is that something then that people should be taking baclofen for possibly before getting into the bedroom?
Yep. I'm not telling someone listening to us to load up on baclofen without talking to their doctor, of course, but yes. So if you have spasms which interfere with physical therapy, I will frequently encourage the person to take an extra baclofen pill prior to physical therapy. Well, sex is in some ways kind of like physical therapy. It's doing a bunch of activity. And so it may, in the same way, benefit you to take an antispasmodic before intercourse so that you don't have spasms. Now, again, if that's not the way that your doctor's prescribed it, it's definitely appropriate to ask the doc and make sure that's okay. But I think that the thought process is spot on.
Okay. All right. And going back to, I forgot my question. See, oh my God, I'm having cognitive issues. I better go get more tea, right? So I really forgot where I was going here. Let me just take a quick look. So using the androgel, primary sex dysfunction. So you're saying then that a person that they should actually go and check out their their T levels and find a course of treatment for that. I just want to re-examine that.
Yep. If you have erectile dysfunction, it's worthwhile to know your testosterone level. If you're a man with MS, it's my opinion, you should know your testosterone level independent from intercourse or sex.
Okay. Next, marijuana, good or bad for the bedroom?
So I have had a couple patients tell me that using cannabis improved erectile function. And I mean a couple, like 3 guys out of a bunch of people having done this job for a decade and a half told me that they have improved intercourse with cannabis. And I think that's fantastic, but I also don't hear that very often. Now, I think, anytime that you use a recreational drug, or if you're using medically prescribed marijuana for an MS symptom, there's a question as to whether or not it could interfere with sexual intercourse or not. I'm not aware of data that it's guaranteed to make it worse, and I don't hear that very often from patients at all. And so if you happen to notice that when you use medical marijuana or cannabis products that you do have an impact, good or bad, that's good for you to know that. But I would say that most of the time my patients do not tell me good or bad. Oftentimes when they're using medical marijuana, the goal is not having sex, to be honest. Oftentimes it's to treat pain or spasms or insomnia.
Right, but while they're doing that medical marijuana for all those different things, sometimes I guess if they're with their loved one and they're both doing it and they both get giddy happy about it, and they just find themselves being a little bit of amorous at the same time, maybe that's what makes it work, right?
I think that's fantastic. And if that's an outcome, then that was a fantastic evening, and yay. But I'm not aware that it'll worsen sexual function.
Okay. All right. We've beaten the hell out of all those questions, all right? And I know I said that we're not going to do anything off topic from the topic, but we do have some other questions here that I think that maybe we can ask tonight because I don't want to wait for Saturday. And by the way, the reason why I'm mentioning Saturday, everybody, is I will be in Columbus, Ohio with Dr. Boster to do a live in-person program Saturday at lunchtime, okay? And this is going to be the first MS in-person program in the state of Ohio, and MS Views and News is doing this, okay? And I say the first, I'm talking about the first since the pandemic and the shutdown, all right? And just to let everybody know that MS Views and News is now doing live events in various places. We are starting in Columbus, and in July, we're supposed to be in Jackson, Mississippi, but if they keep surging upward, I'm not going. I will easily cancel my plane ticket because of that. All right. But in August, we're to be in Roanoke, Virginia at the beginning of the month, and Greenville, South Carolina in the middle of the month. And then September, we're in Atlanta and just north of Detroit. So, we're trying to get out there and do different things. And yes, somebody just wrote, what about Louisville? Well, the answer is yes, we will be in Louisville, but that's in December. All right. It'll be the first week of December that we're there. We don't have anything lined up yet for Louisville as far as speakers or whatnot, but who knows? Maybe Dr. Boster will say, hey, I'm going to go for a car ride down to Louisville.
I'll do it in December.
Okay, well, that's good to hear. All right, so one of the questions that came up, and this is COVID related, all right, is a WWBD, they're calling it. What would Boster do about unmasked, unvaccinated coworkers in a confined space while my MS treatments lower my vaccine's effectiveness? So I guess that person might be using a B-cell depleter. What can you tell? What can you do to answer about that question?
So that's a tough one, and that's very real world. In different sections of the United States have different mask laws and requirements, and culturally, there's different parts of the United States where masks and social distancing is more or less enforced or abided by. And so I'm seeing and hearing this all the time from patients in clinic. So we have a situation where you want to be safe, right? And you've gotten vaccinated, but you're on a B-cell depleter or you're on an S1P1 receptor modulator. And as a result, you might not mount an adequate, robust B-cell response. And then you have a bunch of other people who have opted not to get vaccinated and they're not wearing a mask and they're breathing all over the place. So what do you do? So that, I really think there's multiple steps involved. Step number one is if you have to be in that environment, you better be damn sure that you're wearing a mask. And the mask needs to cover your nose. This is not useful at all. This does not protect you because the virus can go right up your nose, all right? So I've seen people do this also. It's a nose mask. This is not helpful. This is not helpful. In order to be helpful, we have to get the mask over the mouth and it needs to be over the nose, okay? And so that's the first thing is I, Aaron, am vaccinated. I'm not on a B-cell depleter and I wear a mask when I'm out of my house all the time. When I'm not in my house, I wear a mask. And when I'm in my office, outside of my physical office space, when I'm in my clinic, I wear a mask because there's no point in me taking a risk, none. And the person that's asking that very important question, number one, is I want them to wear a mask. And when the person says, hey man, why are you wearing a mask? Say, because I'm immunosuppressed and you won't keep me safe. You refuse to wear a mask and it puts me at high risk. And so all I can do is protect myself. And then I would hand them a mask and say, would you please help me by putting this mask on? Because you care about me as a coworker the same way I care about you, and ask them to wear a mask. Now, that's one thing. And we could have a whole discussion about the psychology of asking that, et cetera, et cetera. But that's one thing you can do. Another thing you can do is you can talk to your HR and say, I'm being placed in a work environment that places me at risk. And I want to de-risk my work environment. Is there another location that I can work in where I'm not in close quarters? Is this something that I can do from home? And so there's been a lot of my patients where we've written letters recently informing the employer that no, they cannot go back into that environment because they're still suppressed and the precautions in that environment are not adequate. And so I think that is an appropriate thing to ask of your employer. And I think it's an appropriate thing to ask your MS neurologist to help you with. So those are two things that you can do. If I had a choice, I would not place myself in that environment. Although, let's be honest with each other, we have to work sometimes. We can't just, ignore those kind of things. And so sometimes we have to come up with ways of dealing with them. And I hope the suggestions that I've made help.
Great. So thank you for that. I've seen a lot of people, I've seen a lot of businesses, I've seen a lot of people with wearing a mask on their chin or under their chin and arguing with people that they're wearing a mask.
Well, it's kind of like, we're talking about sex earlier. If you put a condom on your finger, it will not prevent pregnancy. It's inadequate.
Well,
and so
depends on how low your T is.
So, doing this would keep your chin warm, but it's not going to protect you against COVID. If we want to do COVID protection, it's up like this.
That's right. Okay. So a person, going back into the sex questions right now, because all of a sudden we got some guys asking questions here. more questions. I wanted to ask whether the generic version of Viagra, or I wanted to ask whether the generic version of Viagra, Sildenafil or something like that, is that
Sildenafil.
still good enough?
Yeah.
Okay. Is that still good enough?
Yes. So when I write for Viagra, I write for the generic. I have not found a difference myself in branded versus unbranded Viagra. Sildenafil works great. In fact, let me tell you another trick. Remember I talked about the Good RX trick, where your doc writes you a script and then you use the Good RX coupon? There's actually other indications for sildenafil. Sildenafil comes in 20 milligram tablets for pulmonary hypertension. And if you take 20 milligrams times 5, that's 100 milligrams. That's the same thing as a pill of Viagra. And so that's, and so there's lots of different ways. But each individual human will determine for themselves whether that drug, the generic, works for them. My experience has been, by and large, it's absolutely as effective.
Okay, thank you. All right, another person is writing, if someone is COVID vaccinated but is exposed to the virus and actually test positive with or without symptoms, can they still shed the virus even though they were vaccinated?
So that question is tricky, because if they're vaccinated, they may mount antibodies because they're vaccinated. So if you're checking antibody tests, that's not going to tell you whether you've been infected necessarily, because you've been vaccinated. Now, if you've been vaccinated and then you do a nasal swab and you find that you have COVID, that's different. So let's take that question, all right? Let's take a situation where they have a positive nasal swab. Just because you have a flu vaccine doesn't mean you're not going to have flu. And just because you have a COVID vaccine doesn't mean there's a 0 chance of getting COVID. What we found is your risk of getting COVID is a lot lower, your risk of transmitting asymptomatically is lower, and the risk of severe infection is lower. But you can still get it, which is why, in part, I'm still wearing a mask when I go outside. And so that is possible, and we ride that out the same way we ride out any other COVID. I've seen it many times with my patients, and it's something that we have to be aware of, and we have to treat it accordingly.
Okay, great. Thank you. All right, so another person I'm going to, okay, all right, he hadn't asked, all right, somebody just saying something that they need a boilerplate letter for something, but I'm lost in train of thought here of what you need the letter for. So, Mr. KH, if you can write it back, that would be great, all right? Just tell me what you need the boilerplate letter for, and then I'll ask the question. Thank you for that. All right, and while he's doing that, I'm going to get into another question. How can you tell what your symptoms are for MS? And that's a really wide open thing there, but I want you to see if you can answer that in 30 seconds or less.
All right, ready, go. MS affects the supercomputer that runs the body and the superhighway, the spinal cord, brain. It can do almost anything. If you ask the question, could MS cause blank? The answer is that it could. And so human beings don't experience MS symptoms, they experience things. And so if you have a numb leg, we don't know what it's from. We don't know whether it's MS or an attack or something else. And so what your responsibility is to bring that to the attention of your provider, and then your provider is obligated to figure out what's causing it. I think playing doctor in the bedroom might be fun for some people, but Dr. Google is not fun. Do not play Dr. Google. Bring that symptom to your provider and let them help you sort it out. 30 seconds, bam.
Okay, thank you. All right, going back, KH answered, all right. So is there a boilerplate letter for HR, Human Resources, about not being safe in the open, maskless environment?
I have not seen a boilerplate letter. You might look at some of the societies, MSAA, MS Society, and see if they have any things on their websites. I suspect that your MS neurologist has a letter because he or she has probably written it hundreds of times. We certainly have boilerplate letters that we adapt to fit the individual person's needs. And so I would start either by looking at the societies, or I would ask your neurologist what they have available.
Great. If anybody asks MS Views and News for this, we don't. Okay. In fact, depending on the state, depending on the environment of the state, you're going to find that employers really don't care whether you like it or not. that they're not doing things a certain way. So, that's the hardship that for those that have an illness of any type, a disease or whatever you want to call it, and are having to go back to work, what they're having to deal with, what might be right, your employer may not. And so trying to get their HR to do something might be like beating your own head against the wall. So, it might be best for you to find out, in my opinion, if you could work remotely, and then you don't have to be around these people. But I'm not the doctor here, so I should let him answer that.
Stuart, I agree with you. I think that if we've learned anything from 14 months of a global viral pandemic, it's that all of those old HR guys were dead wrong. And you absolutely can do a lot of work remotely. And that's a change. Now, the sad thing is people in the chronic disability community have been screaming for remote work for decades, and nobody's listened to them. And it's not until the entire healthy, able-bodied world was dealing with the same things before they tried it out. But now we know it's true. And so, as, for example, we're starting to bring people back into the workplace, it's not one size fits all. And if you are on an immunosuppressant agent, which is making it so that your vaccine is not fully adequate or what have you, that's a moment to talk to your office and say, you don't want me to get sick and you don't want me to give sickness to everyone else. You want me to continue to work from home. Remember, I've done a great job for you for the past year. How about I keep on keeping on with that great job? And by the way, here's a letter of medical necessity from my neurologist who is stating that it is medically necessary that I'm not in that environment. Now, the employer can push back, but they are not likely to argue with a medical necessity. They have to be very cautious doing that because there are laws in the United States for the American Disability Act that protect us. And so your doctor is very versed in how to write those letters for a reason. And I think that we need to work with employers. We need to work with HR so that we can all be successful. And I think sometimes that involves thinking about doing things out of the office.
Okay. All right. I'm going to ask one more question and then we're going to call it a night, okay? Mainly because I have to be on the plane first thing in the morning and I got to get some beauty sleep, all right? All right. A person is writing, I get migraines. Cialis triggers these migraines within 24 hours. Do you recommend taking a triptan at the same time as taking Cialis? Alternatively, would taking a lower dose of Cialis each day solve the ED issue and prevent migraine?
So the first is the same disclaimer that I can't give that individual human medical advice because I don't know enough about them to answer. I would share with you that I like the fact that you're trying to game out different ways of doing things. I would not personally recommend that someone take Cialis and Imitrex or some other abortive agent at the same time. That would not be my personal recommendation. Your neurologist may feel differently. I do think that playing around with dosing is an excellent idea because, just like with makeup, less is more. And if you can have an adequate erection for penetration with a lower dose, yay. And if that results in no headache, super yay. So I really like that line of thinking. The bottom line is I think you need to go back to your provider and say, hey, this helps, but there's a lot of side effects that I can't handle. Help me with something else.
Fantastic. Fantastic. By the way, everybody, I mentioned earlier that I'm going to be in Columbus, Ohio. Just so you all know, we're doing it virtually also. It's not just in person. So whatever we were doing virtually, some of them are now becoming in person and remaining virtually. Why? Because we get bigger audiences that way. So we could have, a very socially distanced program where we're, using a lot of square footage to put less people in that square footage. All right. And that's great. Okay. But we're capping all of our programs at a max of 50. All right. And that's it. I'm not interested in the 100+ programs yet. I mean, maybe in several months. But at the same time, we are doing these all as virtual events as well. So the program we're doing on Saturday with Dr. Boster, if you go to the MS Views and News website and you go to the registration area, there's a section there that you can click on to be part of that virtual program. And then it's about MS. It's not about, what we talked about here tonight. So we're talking about MS. We're talking about MRI. We're talking about disease progression. We're talking about the invisible symptoms of MS. All right. And that Dr. Boster will be speaking about all of that on Saturday. It is an 11:30 a.m. Eastern Time program. And whatever questions you have, you'll be able to ask them online, just like you did here tonight. Only on Saturday, I'm going to say your first names again, okay? Not your last name, just your first name, all right? And that's the way we're going to do it, all right? So I hope everybody can join us and have a good time with this, and I hope that you all got something out of this tonight. If you have any questions for the doctor that you think about afterwards pertaining to sexual health and dysfunction and MS, for the guys out there, please send me your email, and I'll be more than happy to send that off to the doctor as well. And for all the guys that are writing, thank you. Great program. Much appreciated. Great webinar. Stuart again, blah, blah, blah. Say, have a safe trip. Yes, thank you. I will. MR. Okay. And be well, everybody. Okay. Dr. Boster, thank you very much for being online with us tonight. It was an awesome event like usual. And I can't wait for Saturday's event because that's going to be really, really awesome, okay? Back in person, doing it live.
Thank you so much for including me tonight. This is an under-discussed topic. I want to thank MS Views and News. I also want to thank MS Views and News for being leaders in bringing patient education during this pandemic. You guys were out there in the trenches bringing virtual programs a couple times a week, and I am so excited that we're now going to be doing these hybrid programs. I'm so excited that I get to be included and that we're bringing MS Views and News to Central Columbus. So as always, my name's Aaron Boster, and thank you for learning about MS with me, and I'll see you with Stuart this Saturday. God bless and have a great
Saturday.
night.
Great. Masked also. Thank you. All right. Be well, everybody. Take care and have a great night. Thank you. Signing out.